It's really a great pleasure for me. And today we are here in the next 50 minutes to take on with the discussion of acute pancreatitis. What is the basic guidance we are going to follow? And still, still it's a critical challenge to address the entire pancreatitis in our field. And the basic introduction, epidemiology, pathophysiology, how are you going to approach a patient, and once a patient is going to land up with complications, how are you going to tackle with your medical management as well as your endoscopic intervention, and how are you going to follow? That's the basic area for us to take on with the considerations. And as you all know, any inflammatory, if it is going to happen in your extracellular portion of your pancreatic parenchyma, it's nothing but your pancreatitis. And once a patient is going to land up, you need to identify whether the patient is having evidence of acute or chronic pancreatitis. What is the basic definition? As you are well aware, there might be evidence of your enzymatic elevation along with abdominal pain will be a characteristic presentation. Abdominal pain will be a characteristic presentation along with evidence of the pancreatitis. And there are so many criteria as such related to severity, and one basic criteria of pancreatitis that we are not supposed to find. So what is this? What are the various scoring systems? As you are well aware about the Ramsey's criteria, the English criteria, Glasgow's criteria. If the patient is having, for example, Apache, acute physiology, and chronic intervention, in this scoring system, if it is going to be more than 8, or your modified Marshalls, there are 6 parameters like respiratory, renal, hepatic, cardiovascular, hematological parameters, neurological parameters. All these things you are going to take into account. Once more than 2 organ failures, if you are going to look into that, the patient shows evidence of your acute pancreatitis, worsening of severity is happening. In Indian scenario, the epidemiology will be going almost around 35 to 40% of the population per 1 lakh. So in global, almost around 5 to 80. And in Indian scenario, the common etiological agent is still a questionable. So whether it is alcohol induced, most of the centers in other parts they will do alcohol. Apart from the gallstone is also to be considered. But in the global population, gallstone will be more common. Apart from other etiology like your post-traumatic, your drug-induced, ERCP around 3 to 5%, and vasculitic profile, and idiopathic around 10 to 15% of the population will be having an etiological preponderance. And male is more than female in case of alcoholic, and female is more than male in case of gallstones. And apart from that, epidemiological racial distribution is also there among blacks. The very important concept briefly about your pathophysiology, 3-8-8-8, any alcohol, your hypertriglyceridemia, whatever, that should be considered as a first aid. And once the patient is going to land with the first aid, followed by the patient is going to land with the evidence of systemic inflammatory response. That is your second aid. So what is the systemic inflammatory response in case if the patient is going to land with the evidence of tachypnea or tachycardia or respiratory compromise, if the total count is going to be the higher side or the lower side, or if the patient is going to have persistence of your fever, or that shows the patient is having evidence of your SARS criteria is going to fulfill, and the sepsis, severe sepsis, organ failure, multi-organ dysfunction. The third aid will be your infection. Once the patient is going to take on with your bacterial translocation infection, which can predispose to patient to various phenomena like your necrotic changes to get affected your pancreatic mucosa. So that's the third aid. And we should not forget the major things. In case if it is the zymogen component, the trypsin activation, the compartmentalization process, and trypsin, the various enzymatic mechanisms which is going to get released, all these things will be predisposed to microcirculatory failure that will lead to pancreatitis collapse in the patient. And as I already discussed, huge list of etiological causes, mechanical, metabolic, and all these things. Clinical manifestations, very common abdominal pain, predominantly stabbing pattern, epigastric radiating prior position the patient will be accumulating and frequently will be going into, and various signs for postgraduate you should not forget, like your gray turners, colors, or fogs. Even then, your Bryan sign, your Tornberg sign, there are so many more than 10 to 15 signs are there. You need to look into acute pancreatitis, whether the patient is having evidence of worsening, because the patient will be having microcirculatory dysfunction in this kind of scenario. And apart from that, various metabolic coexisting complications like your hypercalcemia and various signs to look for your Church-Tex as well as a Clausius phenomena. And apart from that, various other complications like your DIC, erosions, or pancreatic injury. All these things are very pancreatic collection. We need to look into all those pictures. So the first week of presentation, how are you going to approach once a patient is going to survive with the second week or third and fourth week, how are you going to tackle? That's all we need to see with the patient. So any patient who is coming to the common natural history, how the patient is going to get progress. It will be interstitial pancreatitis or necrotizing pancreatitis. Necrotizing will be around 10 to 15% of the population, and more than 80% of the population will be having interstitial. And once a patient is going for necrotizing less than 4 weeks and more than 4 weeks, that classification I will take on. And mortality, this is taken from GUT 2017. Once a patient is going to land up with evidence of severe, which means the infected necrosis event is going to take on with this kind of patients in the background of severe pancreatitis, which is happening in 20% of the population. There will be 15 to 35% of mortality will be there when compared to sterile necrosis will be around 13% of the population will be in mortality. And nowadays, apart from your enzymatic elevation, so many new biomarkers like your hematological based, your CRP is going to go 150, your procalcitonin and interleukin 6, interleukin 8, so many markers are there. Hematological parameters. This biomarkers itself being considered as a separate thing to assess in patient with acute pancreatitis. Your neutrophilic lymphocytic ratio, monocyte ratio, all these things. Nowadays, pre-sepsins, all these things in trials. This is all the upcoming areas we need to look into the biomarkers apart from your amylase, lipids, and all those things we need to see. How are you going to recognize this patient in the phase of acute pancreatitis? And beyond these biomarkers have already been discussed, your microRNA, trypsinogen activation peptide and cytokine panels, your AANS integrations can be considered. And briefly about the very important area about pancreatitis is the management guidelines. So still we are having so much of questions to address in this area. Mild pancreatitis, always conservative, start the patient and conservative management, and then if the patient landed with evidence of severe. So very important, assess for organ failures, fluid loss. There are multiple papers to look for this goal. What does we need to target? That is waterfall trial. We should not forget this. So what is this waterfall effect? There should not be aggressive hydration as per recent IAP position statement in 2025. So you should not go aggressive hydration. So around 10 ml per kg, borders is maintained by 1.5 ml per kg per hour. That's to be considered rather than going for 20 ml per kg fluid borders, which is predominantly your ringer lactate because to prevent your hypochloremic acidosis and other complications. And we need to maintain a target that's very important, 4.5 liters rather than going for per day. It's better to go with not aggressive approach of 3.5 liters per day with your fluid solution. That's all. So we need to target with your mean arterial pressure should be more than 65, your urine output should be significantly improved, and your hematocrit parameters has to be improved when you're going to assess your fluid therapy. This is what we need to look into that. And pain mechanics, aims, so many guidelines are there. Pentazocin, diclofenac, your buprenorphine, so many molecules are there, starting from your paracetamol and basic NSAIDs. You can step up your management based upon the clinical presentation. And analgesic evidence as per pentazocin in the dose of almost 30 milligrams of diclofenac in the range of 35, we can consider that. And prophylactic antibiotics, still we have so much of questions, there is no major role. And once the patient is landing with evidence of infected necrosis, prolonged sepsis, organ failures, multi-organ involvement, and if the patient is having fungal septic focus, other organ, extra GI source of like bacteria, UTI, all these things we can consider prophylactic antibiotics like your tazobactam along with the independent group of celastin derivatives. So you can consider, but still in the early phase, no role of prophylactic antibiotics as per AGA as well as the IAP. Nutrition, very important, we need to look into the early phase. But we are going to start by 6 hours or 24 hours, this is still a questionable issue to address. So early enteral nutrition is very important rather than thinking in terms of prolonged nutrition. So if enteral nutrition is not possible, we can go for parenteral, but rather than that, so fasting, we should not be starving, should be avoided most of the time when we are going to charge the patient with pancreatitis. And enteral route, in that NG will be more preferred rather than NJ because of cumbersome issues and moreover the cause and other factors. So basic guidance is sterile necrosis prevention, hydration is important. Infected necrosis, early enteral feeding, and infected necrosis you need to choose with antibiotics, drainage as well as necrosectomy. So before taking on with the endoscopic interventions, the ERCP in biliary pancreatitis is more common scenario. So once a patient is going to land with evidence of cholangitis or acute persistent biliary obstruction, then we can consider the patient within a span of 24 to 48 hours your ERCP. But if the patient is not having any worsening of events, then we can postpone the patient up to 4 to 5 days even for your biliary skin problem to be considered. And Once the first week is gone, so when we are going to enter the phase 2, second week to third week, so what are the major things you need to see? One, whether the organ failure is there or not, whether the patient is improving or not, whether the nutrition is adequate or not, whether the patient is having fluid overload evidence is there or not. Apart from that, whether the patient deserves antibiotic support or not, whether the patient deserves endoscopic intervention or not. These are all still we need to see whether the patient is at week 2 to 3. And nutrition, as I already discussed, 1500 to 2000 kilocalories per day we need to maintain, and conservatively all drainages we need to manage. Only if the patient is symptomatic, then we can go for further interventions. And two factors will determine the collections. One is your necrotic size as well as your large size of cystic lesion. And so this is what I would say. Any patient you can start with conservative, percutaneous strain, and minimally invasive necrosectomy. So what is this basic thing we should not forget? Very important flow chart. You should not forget that if the patient is having acute and chronic, acute peripancreatic collection, necrotic collection, nothing needed. Just wait, watch, see whether the patient is responding or not. Pseudocyst, see the size. 5 centimeters, 10 centimeters, 15 centimeters, and more than 15. If the patient is having more than 15, then we can go for endoscopic cystogastrostomy. As we are well aware, place it like US guided, we can place, dilate, and then we can place your stent like your plastic or your lumen opposing metallic stent like your Artaxias or your Spaxis or Maggie. Whatever the best of thing which is physically in your limit, you can choose. But in case if the patient is having worsening changes like your necromina, what of pancreatic necrosis in which there will be lining with the necrotic changes, the sterile component will not be there in the cavity. At that kind of juncture, you need to choose. In that area, we can go for your direct endoscopic necrosectomy through your cavity, through the stent which you are going to place. So that's what the then procedure is going to consider. And apart from that, various, so once you're going to do your direct endoscopic necrosectomy, you can either snare it out, or you can place some insulin solution like your NS or ringalactate or your hydrogen peroxide or your bacillus or some other things of antibiotic you can instill, and 3 to 4, 5 to 6 sessions you can do to prevent the worsening changes. But how long you're going to retain these lamps? This is very important. If you're going to place a lamp, ideally for 3 to 4 weeks we need to remove, or in case if the patient is going to be on plastic stents, you need to retain the patient for around 4 to 8 weeks. Apart from that, what other modalities is there? Percutaneous drainage. Suppose, for example, if the pancreatic fluid collection, if it is there in the still more in the vitreoperitoneum or in the paraphoric gutters or mesocolon, in this area it is very difficult to access that area by your endoscopy, which you could be able to access the port. At that point of juncture, you can use a percutaneous drain, and through that we can go. If it's still more complicated, we can go for surgical, minimally invasive procedure like your video-assisted VAD procedure, video-assisted retroperitoneal debridement. These things we can plan out once the patient is going to land with evidence of pancreatic fluid collections and other complications. And this area already been discussed. 80 to 90%, more than 90% will be having a normal resolving without any major issues, but 5 to 10%, as I discussed, will land up with this kind of complication. And serial follow-up is important. How frequently we are going to monitor, that's important. And this is how the basic outline for your acute pancreatic fluid collection, necrotizing collection, your pseudocystic lesions to get formed in which your wall of pancreatic necrosis has been evolved. And I already discussed ongoing organ failure, GO, refractory pain, or infection if the patients are bleeding, which is acute presentation. And always we are not supposed to find one important entity when you load the patient with fluids, abdominal compartment syndrome, in which the intra-abdominal pressure if it is going to be more than 20 millimeters of mercury, we need to be cautious. So fluid diuresis, and main always try to decompress the gut, that's very important. And if the patient is not responding, then we need to place with further line of management like a surgical intervention, the other thing. Basically, always try to delay any lesions. Pseudocyst more than 4 weeks if it is the brain, and wall of pancreatic necrosis try to debride. And this is the final flow chart. See through that necrosis and all those things, and make sure whether the patient is going to do a successful endoscopic intervention being desired or not. And direct endoscopic necrosectomy also can be planned out. And these are all the various papers. For example, there are various trials. One is your penguin trials. Apart from that, your miser trials, tension trials. There are recent trials are there that show that endoscopic debridement will be having a significant potential role rather than going to consider the patient for surgical intervention. That's how been proven. And before concluding, very importantly, what you're supposed not to forget, always recognize the patient in early phase, try to manage the patient conservatively, see through that for evidence of organ failure. It is really a difficult task for most of the scenarios. As a practicing gastroenterologist, recognizing the organ failure and how to intervene the patient in organ failure. Let's assess the complications like your splenic artery aneurysm, your embolism changes, and apart from that, once the patient is having any bleeding manifestations, or if the patient is having any other further complications like your other manifestations that tends to get there, then you need to be cautious to address that kind of presentation. With this, I'm happy to rest. Thank you very much.
Thank you, sir, for the